And also an alum of HPM, and really excited about this opportunity to let you hear from one of our colleagues at the American Hospital Association. We have a slide that's posted now. We actually have a public LinkedIn page, and we want folks to follow it. So please, if you can take the opportunity to scan the QR code there and follow us on our public LinkedIn page, we would appreciate that. We want to be respectful of everyone's time, and so we're going to now have Wenji Mao, who is the chair of our HPM Alumni Council, also an alum of the department, and one of the C-suite members at the Texas Health Resources, is going to come and get us started. Wenji?
Thank you, Jeffrey, and welcome to all of you on this webinar, and thanks for being with us today. And thank you, Lisa, for joining us. I'm very excited to hear what Lisa has to say and her insights with her work at the American Hospital Association and what is coming to be in 2025 with the new administration. So Lisa Hrobsky is the Senior Vice President, Legislative and Political Affairs at the American Hospital Association. She directs and oversees legislative advocacy initiatives, grassroots efforts, and the AHAPAC engagement activities for the association. She is a key spokesperson for the AHA with Congress, the media, and other stakeholders. She served as the president and CEO of the Idaho Hospital Association, where she was responsible for directing and leading the association in its mission to strengthen their hospital and health system's viability to serve their communities. Early in her career, she worked on several positions on Capitol Hill and specifically around healthcare, Medicare, and Medicaid policy. A native of Idaho, Hrobsky earned her bachelor's degree from Boise State and attended graduate school for an MA in political science at the University of Idaho. So without further ado, I know we're all here to learn from you, Lisa, so I'll let you take it away.
Great, thank you. And I hope that I'm able to teach you something and that you are able to learn. Things are really up in the air right now. I think it's probably all of you have seen on the news and have been watching, but I'll try to bring you as up to speed as I can in the time that we have. I don't think I need to go through the election results with you. I'm certain everybody by now is aware of the outcome, but I do want to lay the foundation for what this election is going to mean for hospitals and healthcare. Obviously, President Trump is coming back in. What is important to note is that he's coming back in really as sort of a fifth-year president, as opposed to a first-year president. Usually it takes the administration time to get up and running, to sort of gather themselves. The Trump administration likely won't have that this time. They're going to jump right in, and we expect them to get to a lot of action really quickly. So that's going to sort of, I think, set the pace for 2025. You may have seen as well that the House of Representatives stayed Republican. They have at this point a 3-seat margin, which is really, really close, 220 to 215. And 2 of the Republicans will be leaving to take positions in the Trump administration. So you can see it's really down to a very narrow margin. So they're either going to have to try to be more bipartisan, which I don't know if that's going to happen, or each party is really going to have to keep in line their members and make certain they're sort of voting party line. But that's going to be an issue that we'll all be watching really closely this year to see how the House can navigate itself. And then on the Senate side, you may have seen that the Republicans picked up the Senate. It was Democrats led it. It's 53-47 seats. And while that might not seem like much of a margin, it really is an important and good number for the Republicans because it means they will able to get through healthcare items on reconciliation, which I will go into in a little bit. But that's sort of the background of what we are looking at and how we expect things to shake out for the Republicans this year. I will flag just the new administration has new players that are coming into key healthcare positions. I think my colleagues and I all have been talking amongst ourselves that if you had paid us like $1 million in advance to name who we thought was going to be in these positions, we would have missed them all. It's just a surprise. So we knew that Robert F. Kennedy Jr. was being discussed, but nobody thought it was happening. And then Dr. Oz. So you just see a sort of a confluence of a bunch of different people moving forward. So a lot for us to learn, new relationships, I guess is how I would say we're looking with this new administration, because these are all new players from when his first administration. The other thing I will flag on administration and sort of personnel decisions they've been making, you may have seen that President Trump announced something called DOGE, although some people are calling it Doge. I don't know. We'll find out how we pronounce it at some point. But this is the Department of Government Efficiency that President Trump, or President-elect Trump, has asked Elon Musk and Vivek Ramaswamy to lead. So they are undergoing efforts. They plan to look at all federal agencies, all the bureaucracies, and slim down as much as they can on some of these spending issues. They have talked about looking at administrative reductions, regulatory burdens, additional personnel. So that's sort of a new bucket. They're not a government entity. They are not allowed to legislate or to move on their own, but they will be influencing how the administration and Congress works this year. Vivek Ramaswamy did have a quote earlier this year that healthcare is going to be a critical frontier for this group. So I think we can expect to see from them suggestions on cutting down on fraud and abuse and trying to like streamline those systems, trying to streamline HHS, the bureaucracy. We've all heard a lot about how they want to look at NIH and FDA. So I think more to come with Doge, but again, not quite sure what it's going to mean for us just yet. The important thing, I guess, to look at as we're talking about this is really the Republican trifecta. So it is, again, Republican House, Republican Senate, Republican administration. That really means that they are going to feel emboldened to move forward on their agenda. As I mentioned, President Trump is really in year 5, so he's sort of teed up and ready to go. But we can expect a couple of other things that I think, know for certain. I mentioned that 53 is an important number in the Senate, and that has to do with budget reconciliation. Budget reconciliation is a really archaic, odd, horrible process that allows the Senate and the House to move through legislation with a simple majority. So 51 in the Senate would do it. Actually, even 50 would, because J.D. Vance could be the Republican tiebreaker. And in the House, I mentioned again a very short or narrow margin, but certainly they would be able to move something through budget reconciliation. So it's a term we'll all be using a lot this year as we look to what Congress is going to do. They just announced yesterday that they may in fact try to do 2 separate budget reconciliations, which is it is hard to do, but certainly it is manageable. The first one, they're going to focus on things like immigration, defense, energy issues. And then they expect the second budget reconciliation to focus on extending the Trump tax cuts. You may recall that there was $4 trillion of tax cuts expiring at the end of 2025. And so the Republicans trifecta would really like to extend those tax cuts. For us, we are likely going to be included in the second package, healthcare in general. There's some decision making that still needs to take place, whether they want to cut and pay for the taxes or not pay for the taxes. Even if they choose not to pay for them, the expectation is that they will have some offsets in there. And that's really where healthcare will become front and center. We know going into this administration that there are certain things that they would want to look at in budget reconciliation that we would like them to not look at in budget reconciliation. And that includes something called site neutral payment, which is site of care payment and differentials between hospitals and other providers. There is a proposal that MedPAC put out that could save $180 billion by instituting this policy. So that, of course, it's quite a tantalizing option for them to look at. The other issues that they could include would be 340B, which is the drug discount program. They could look at making changes to that. And then I think one of our biggest vulnerabilities really is going to be on Medicaid. Medicare, it's harder to go after, and I don't know why, but the politics of it are that Medicare is more protected than Medicaid. I guess that's maybe the way that I would say it. So we can look at, they would be doing eligibility, they would be doing block grants, a whole wide range of issues they could look at when it comes to Medicaid policy that we're going to have to really watch closely. At the same time, while they are doing perhaps offsets or policies that we don't like, we do expect this administration to be helpful on some of our other key issues. That includes the issues of rural health care, telehealth, regulatory relief, perhaps even bringing med mal liability back into the discussion. So, every administration goes both ways, but we are, excited to see what we can work with them on, and then obviously a little hesitant on some of the issues that we expect to come out. I will just say for our fall agenda, we were really geared up and ready to have lengthy debates and discussions about hospital offsets and hospital policies. Particularly, there's some issues around transparency, site neutral, a slimmed down version that we thought could be up for discussion. It looks like that won't happen now, and that our fall agenda may move into a early 2025 agenda. But certainly we will continue to keep working on those issues because we know they won't go away. Congress needs to fund the federal government. It is one of the main duties of Congress, and they are not great at it every single year. It kind of drives everyone crazy. They were expected to pass government funding by October 1st. They did not. The government funding does expire December 20th, and the sense is that they're going to push it until March of next year to give themselves 4 months to move forward in the process and put together the policies that they want and then take them up. So again, the expectation is that Q1 will be really, really busy on Capitol Hill and for hospitals and health systems. And with that, I'm happy to take questions. That's sort of the broad overview of what we're doing.
Well, thank you, Lisa, so much for that broad overview. You covered a lot of topics, and I'm sure we'll have questions, and again, encourage people to ask questions. I know I've got one, and then I'm going to kick it over to Michael for another one, and then we'll see what the audience has, because I'm sure we'll get a lot of great questions from them. You mentioned 340B. Many of our health systems utilize the 340B program, have specialty pharmacy programs. Can you talk a little about where the AHA expects 340B policy and regulation to move under the Trump administration?
Yeah, so it will be interesting to see how this shakes out. President Trump, for those who don't follow the politics of 340B closely, it really has become almost a fight between the hospitals and then the pharmaceutical industries on making changes to the program and trying to find benefits to the program. President Trump and his administration aren't particularly close to the pharmaceutical industry. They're not particularly close to the hospital industry or the doctor industry. So I think we're all starting with a blank slate, sort of there with the administration, with the key players' thoughts on the issue. However, we do know particularly House Republicans are really very interested in engaging in this issue, trying to limit the number of pharmacies that hospitals can contract with, trying to do the back end, sort of how the hospitals pay for the rebate. So I think lots to watch on that. One thing I will flag for you is that the new Senate leader, so the Republicans again took over, Senator John Thune's a Republican from South Dakota. He is a real friend to hospitals and healthcare. And he has a working group that he has formed on 340B specifically, where he's put in probably a year's worth of activity. So we do expect, if anything moves forward, Senator Thune, Leader Thune, would have a say in it, and that it might be perhaps more helpful to hospitals than without him in his current position.
Lisa, one of the questions that I had, you'd mentioned, potential areas that the new administration would target for potential savings, right? Whether to offset the tax package they'd like to extend, or for policy reasons. And you mentioned Medicaid specifically around that. One of the things that we've been watching closely has been the growth of directed payment programs around the country. These programs, for those who don't know them, they work with CMS in order to get Medicaid reimbursement. So they work with the states in partnership to get Medicaid reimbursement closer to average commercial rates, which, as we all know, both Medicaid and Medicare, AHA, you've done a lot of studies on this, show that the reimbursement for Medicare and Medicaid in there don't cover the cost of care for U.S. hospitals. So this is a program that's really beneficial to hospitals in order for them to better cover their costs, but also to reinvest in their communities and increase access and do all the things for the communities who benefit from Medicaid. You mentioned a couple of different areas that they were looking to maybe trim Medicaid roles, right, in terms of eligibility or other things. What do you see as the future of directed payments? And again, it's a little bit complicated in that it's an entitlement. We also have a number of the states, red states that voted that are important to the Republican Party are directed payment states themselves. So it would be a hit to those states if they were to have that program limited. But where is the AHA right now's thinking on that? And is it a wait and see, or is there some early indications of maybe where directed payments will be as we go forward?
Yeah, I think a little bit of both. You should have been at the AHA yesterday. We had hours-long meetings on Medicaid and all of the implications and concerns we have for Medicaid going forward. So we did talk about this. As I mentioned, we do know that the administration and previous players that they've had in their healthcare arena very much are looking at sort of the provider tax issues. As you know, that's always an issue where they call it a scheme. Is it fraudulent, et cetera? So we expect that to be talked about. We expect work requirements to also be talked about and having states be allowed to use work requirements going forward. But we don't have a lot of specific information right now on the direct contracting and knowing where sort of the players in his field have been. It has not been an issue that's been top of mind for them. So again, I have an answer, non-answer for you. So really, that's one of those they just aren't real vocal on it. But it's obviously on our radar screen to keep track of as we move forward.
Terrific. Well, I'm not sure if there's any questions in the chat. Yeah, I don't know, Wendy, if you see
Yeah, I
any
was
for
gonna, I
There
was,
Jeffrey?
are.
yeah, how about we jump to this one question in the Q&A and then we can go back to other questions that you have. So for everyone who's participating, you can enter questions in the Q&A section of the webinar. And here is one question that we have is Dr. Oz has proclaimed Medicare Advantage for all, but Congress has several committees examining many complaints about Medicare Advantage. How do you think Medicare Advantage will be different in a year or two from now?
Yeah, I do think that Dr. Oz had been very public about the fact that he likes the Medicare Advantage program. He thinks it's beneficial. He doesn't have real concerns with the program. Saying that, there are, as was mentioned, there are a lot of activity, or is a lot of activity on Capitol Hill looking at Medicare Advantage specifically and sort of consumer insurance accountability. So I do think there will continue to be scrutiny of the MA programs and their use of prior authorization. And some of the other issues that they've had in provider directory, et cetera. But the expectation then is that Dr. Oz probably won't cut MA funding, which is really where people were going, is that the MA plans are getting paid too much. It was too much of a chunk of the federal government, and they wanted to pull it down. That's uncertain if that's going to continue with the new administration. But I do think on the regulatory side, there will be some changes that are helpful to hospitals and all providers. But yeah, I think that there will be more favorable treatment to MA than there had been previously.
Lisa, tangential to that, there are other Medicare payment programs, MSSP, and then, for example, the ACO REACH program and CMMI, some of the CMMI pilots and the service line bundles. Where do you see kind of the sustainability or longevity of those programs? I've heard mixed things in terms of CMMI and whether that will remain solvent.
Yeah, I think that there's going to be a lot of investigating and oversight of those committees. You may have seen that a few months ago, House Republicans, the Budget Committee, who obviously has control over spending, and some other members sent a letter to, now I forget, it was the CMS or GAO, asking to do a further deep dive on the program. About $20 billion has filtered through CMMI to go to places who are working on ACOs and these type of plans. The most recent estimates that came out from the government, which prompted this letter, was that it is in fact not saving money and that it's costing the federal government billions more than anticipated. So I do think that there's a real concern on Capitol Hill as to whether CMMI and some of these programs are working as they were intended. You may have seen as well, obviously, there's an attempt, and DOJ might be part of this, to sort of shrink healthcare and shrink the government. So this could be one of those that they're like, hey, this isn't working the way we want it. Let's shrink that program. So I do think it will be certainly in the spotlight.
So we do have one question from one of our webinar participants. Is it assumed that the new administration will seek to repeal the ACA again? And if so, what would you anticipate would be different factors to its success or failure compared to the previous attempt in Trump's first term?
Yeah, I think that a wholesale attempt at repeal and replace is pretty unlikely to happen. There have been conversations where at some points during the campaign, President Trump said that he would like to do a repeal and replace and that he had a plan. But I think the general sense is that repeal and replace likely wouldn't get done as a whole. What is a major concern for us and what we are for next year is the ACA tax subsidies. This was a program that came out during COVID where there were increased subsidies, enhanced subsidies for people. They expire at the end of 2025. They have the same deadline as the expiration of the tax cuts. So the sense is that those two policies would ride together. And again, the enhanced benefits allowed people above the previous federal poverty level to gain access to the program. So it really opened up the program to millions more people. What I think will happen is the administration will not just do a wholesale extension of the tax credits for the ACA exchange, and they will scale down eligibility. They will look at certain groups within the marketplace and try to limit them from gaining access. So I think as far as the ACA, that's where the real battle will be next year.
Maybe switching gears a little bit from some of these policy pieces and into some issues that are really impacting U.S. hospitals today and healthcare facilities and healthcare providers in general is the growth of workplace violence against healthcare workers, whether it's verbal abuse, physical abuse, which sadly we have seen. One of the areas that we would like to see happen was just where the AHA is on this today is perhaps getting similar protections for healthcare workers that those who work in the airlines receive, to make it rather than healthcare workers ever actually having to press charges, that there could be active arrest and work to again protect our healthcare workers and give them a sense of security and safety in the workplace. So just wondering your thoughts on where that is from a policy perspective. Is there any interest on the Hill to support that, or have you heard anything that may be coming from the new administration?
Yeah, well, you are singing our tune when it comes to healthcare violence. We have worked with members of the House and the Senate to introduce legislation this year that would federalize crimes against healthcare workers similar to those in aviation. There's also additional grant funding to help hospitals move forward with their own sort of what works best in their community violence prevention. There is an interest in doing something. I would say that on the House side, in the House of Representatives, we had a Dr. Bouchon introduce this legislation for us. And we've gotten over 100 co-sponsors. We might be close to 180, but a really good number of House members who are engaged and interested in helping on this issue. On the Senate side, it's been a little bit different. We do have legislation introduced with Senator Manchin from West Virginia and then Senator Rubio from Florida. Senator Manchin's retiring. Senator Rubio's presumably going to become Secretary of State. So we're going to have to start over in the Senate to engage them. The one thing I would say is we on our job generally talk to healthcare staff and healthcare people, but this is going to the Judiciary Committee. So it's a whole new sort of angle for us to involve them and make certain that the judiciary staff understand the healthcare issues. So that's been a little bit of a hindrance. But again, we're going to move forward next year. The expectation is we'll find new champions in the Senate and move forward with the policy.
That's terrific. Thank you for all the really great advocacy in that area.
How about we go to our online participants? There's a question looking into the future, and with Trump returning back, can you speak on what are some emerging healthcare policies or trends hospitals should be prepared for in the next few years?
So I do think that people may recall back in the first Trump administration, President Trump did put together transparency regulations on hospitals and insurers. I think we can expect him to keep moving forward with those issues. I think that transparency has become a very big issue for him. We know he has good friendship with a lot of people who are engaged in pushing transparency and that he listens to them. So I think we can expect transparency to be a really big issue. You may recall as well, surprise medical billing was an issue that the Republicans had looked at. I don't know that they'll bring it back up after the sweeping legislation passed, but I do know that there's still some concerns with how arbitration is working. So we may expect some insights from him there. And then again, as I mentioned, I think the biggest vulnerability right now is probably Medicaid. And then right under that, you're looking at Medicare cuts to hospitals that are just unsustainable. So I think that that's where he'll be focusing and where we'll be focusing.
One more question online, Wengie, before we come back to you. And again, all online participants, you can enter questions in the Q&A icon on your screen. On a workforce-related note, do you anticipate any efforts to address the workforce shortage, both in institutional and in-home and community-based settings, e.g. home care?
Mhm. I do think that there is the opportunity to work on workforce. This is an issue that really has bipartisan support. People on both sides of the aisles, both chambers really understand what's happening. As a result of COVID, they not only heard from the healthcare industry, but they heard from a lot of other industries about the workplace shortages and how they needed to focus on getting additional workers into place. There has been a real emphasis in Congress this year looking at workforce, particularly as it relates to mental health care and making certain that there's providers there. And then you may want to watch out for, there is a nursing home ratio staffing rule that was finalized by the Biden administration. The thought is that the Trump administration may pull that back. The nursing home has been very clear that they don't have the personnel to meet these staffing ratios, and that they were really sort of setting the nursing homes up to fail because they wouldn't be able to comply. So I do think that's another issue where he may be engaging in workforce.
Thanks, Lisa. Some great insights so far. We talk about other venues of care. So we just talked about nursing homes and home health, and as many of the hospital systems bring LVNs back into the workforce in larger numbers, what we realize is that we're robbing Peter to pay Paul, because then when we're trying to discharge them into SNF and post-acute, those beds aren't available. You mentioned though, another alternative venue is the whole hospital at home. That waiver expires, and that's also in a bill that's set to be carried hopefully by the end of the year. So could you talk a little bit about both the hospital at home waiver, its status, and where we believe that's going, as well as telehealth, because during the pandemic there was a waiver for that in terms of reimbursement, and whether or not we believe that will stay, or if telehealth reimbursement will revert back to prior to the pandemic.
Sure. So I think to your point that these programs will be extended through the length of the funding bill that the government does. So the expectation is that they wouldn't end at the end of the fiscal year, which they're scheduled to, and they would be kicked down an additional 2 or 3 months. So the good news is short term, we think that these programs are fine. We have heard there's discussions to try to do a 1-year extension to give people a little bit more comfort and stability in the program. Unclear if that will happen. But I do think that there is an appetite on Capitol Hill to look at the hospital at home program and to make certain that it's working for their beneficiaries, for their patients. There is some concerns about the payment level. I guess that's probably the best way to put it, and whether that payment level would remain quite as high. CMS has indicated they want to keep looking at that and evaluating. So I do think that Congress will, again, ask CMS to continue looking at this program, looking at the appropriate payment rates, but I don't see the program going away. Like, I feel like at this point it's pretty ingrained, and the expectation is it will continue in some way. And on telehealth, similarly, a lot of bipartisan support, a lot of interest in telehealth. There are some concerns on Capitol Hill about the fraud and abuse of the program, as well as whether or not the increase in telehealth is going to cause an increase overall in the federal budget. But those concerns aside, I think we can expect telehealth to stay around permanently, the waiver provisions permanently for quite a while.
Thank you.
Sure.
All right, let's go online before your next question, Mike. You mentioned that rural health might be a priority for the new administration, but rural hospitals are highly dependent on Medicare and Medicaid. 2 areas you mentioned would be targets for spending cuts. What benefits do you see for the rural hospitals?
So there is a lot of interest right now on Capitol Hill in helping rural hospitals. So that could be increased funding pool, that could be expansion of the Medicare dependent program, the still community hospital programs, upping those payments. What we are finding is that the administration and members of Congress would like to cut other areas of the hospital field to pay for these rural improvements. So it is for us, it's a tricky one. Again, we're not going to support cuts to urban hospitals just so that rural hospitals can get additional funding. But that's kind of where we think they're going, is that they're going to try to put some offers on the table What we're going to need to do, obviously, is continue to push back and show that rural hospitals do need this support, talk about the closures, talk about the line of service changes that is going to happen. And that will be our strategy there. The other strategy that we think about on rural healthcare is in the Senate. A lot of red Republican senators come from rural areas or have rural areas that they represent. And they generally are really helpful in pushing an agenda forward for those bases.
Jeffrey, did we have another question from the chat? Or...
There are two other questions that are rural focused, and so let's just let me see if I can quickly summarize them. And one is asking, are there any sort of lessons we can learn from Trump's previous administration regarding access to care for rural populations, and does that affect the trends towards rural hospital closures? Any thoughts about or reactions to that, Lisa?
Yeah, I don't have any thoughts on that, which is probably not helpful. He did not, rural health in particular was not a particular focus of his. What I will say is during repeal and replace, the arguments that hospitals and providers across the country made on the impact to rural healthcare is what resonated most with both the administration and with Congress. And we know that from conversations we have and from data and information that we've pulled. So I do think looking to that sort of as a guide, the expectation is he wants either the appearance of or the actual protecting of rural hospitals. So I think that's what I would take from his first year out on the issue.
All right, and then the next question that's rural focused really kind of is asking about social determinants of health and whether you foresee any policy measures aimed at protecting underserved populations through sustained or increased funding for community health initiatives? And specifically, how would the administration support programs that address social determinants of health?
Yeah, I don't know that this will be a top priority for the administration. I know that there is a lot of interest in a bipartisan way on funding things like community health centers and making certain that there are some resources in the communities to help. And that kind of, it's very rural focused. But I don't imagine that social determinants of health will be a really big issue that this administration pushes. You may look back over the last few years in healthcare as well, like social determinants of health is not necessarily, it's going to sound derisive, but I don't mean it that way. It's not as in vogue as it once was. And so I think that a lot of hospitals and health systems who do this work are really doing it internally with their own communities, and that there hasn't been a lot of additional federal engagement or push to sort of move this way.
Thanks, Lisa. With two more, Mike, and then I'll I'll let you have the mic back. Related to access and care delivery, what steps is the AHA taking to ensure that site-neutral payments you mentioned do not negatively affect access to high-quality care in rural and underserved areas?
Yeah, it's a real issue that we are focusing on. As I mentioned, there was some concern with site neutral, for example, that they could have a increased benefit to rural hospitals while taking the payment away from the vast majority of other hospitals. So there's a lot of concern, one, that Congress may try to segment out the rural hospitals and maybe protect the cause from these reductions, although I don't know the cause have them anyways. So that's something that we're really focused on. I will say that we have a full court press really on Capitol Hill on this issue, and have since the beginning of last year, when right out of the gate we testified on the issue. Some of you may be familiar with the Coalition to Protect America's Healthcare. It is a healthcare organization that the AHA started, but it's made up of state associations, hospitals across the country. And part of their messaging this year has been on site neutral, specifically making certain that Congress and staff and the general community understand what the negative aspects of site neutral could be. So we will continue working with the coalition. We've got advertising, we have commercials, all in play, ready for, again, Q1 next year, when we think everything's going to start all over again.
One more question from a participant. Are there allies or partnerships that the healthcare industry is not currently working with that you could potentially see being helpful to work with during this administration?
Yeah, Yes and no. So if you're looking at site neutral specifically, we have really had to dig deep to find some allies on this. There is a whole heck of a lot of folks, the insurers, the doctors, the family physicians, AAFP, some of the consumer groups are really very much pushing site neutral payments. We don't have a lot of allies on that issue. So we're open to working with folks who haven't taken a negative position on that. And then when you move forward to the Trump administration at large and sort of what we're thinking and who we'll work with, we work with on a daily basis, you know, the Chamber of Commerce, AHIP, the Blues, the AMA. We're in constant contact with these groups on a variety of issues. I think what you'll see next year, though, is because we're having this discussion about the ACA tax credits and extending them, the insurance companies really want them extended. This is a direct payment to them, so they're very interested in making certain that they continue. We wholeheartedly support that and work with them. But then you'll see the divergence where they'll support cuts to hospitals to pay for those ACA tax credits. So again, they're allies in one sense, a lot of these groups, and on the other sense, we're fighting, you know, fist and glove or whatever the term is against them. But yeah, we always try to work out and find additional groups. It's much more important than on Capitol Hill, and it resonates when you have a wider group.
All right, Mike.
Thank you, Jeffrey. So, Lisa, as we look back a few years, you know, America's hospitals and healthcare providers stepped up in an amazing way, right, during the pandemic to respond to this national international emergency, and were seen really as heroes and applauded as heroes. And we saw that in New York City every night, right, as the healthcare workers were walking home and people would be out cheering them on, and I think we were all very incredibly proud of the work that was done, again, by America's hospitals and healthcare providers. Fast forward now, we seem to have, as an industry, been targeted as, well, and not as such a good light, that we're the major part of the problem, and that our costs are too high, or that we're not providing services yet. We're at the end of the food chain, right? We're the ones that are open 24/7, providing emergency care. We're there for national emergencies. You look at healthcare and hospital margins around the country, and those are significantly less than other industries, and certainly over the Kaufman Hall's reported over the last couple of years, you know, more than half of U.S. hospitals are losing money and in the red. So it's a very challenging time, and that's due to workforce, the economy. You know, there's a lot of reasons for that. But what's really concerning is this negative narrative against hospitals. And what do you think's driving that? Where are we, and how can we all help support a positive narrative and really get out the real story of what hospitals and healthcare organizations do every day to support their communities?
Yeah, I completely agree with you that somehow hospitals and health systems have lost their shine over the last couple of years, and people have a pretty short memory. From our perspective, we have an initiative underway that we've been working on called Telling the Hospital Story, where we are really trying to push out the positive narrative. So there are stories of what hospitals are doing in their communities and for their patients, you know, on a daily basis. And we want to make certain that the public is aware of that initiative. The other thing that we are looking to do is within the board, the AHA board, they have been looking at hospitals and their image, I guess, for lack of a better term, and trying to figure out how do we compete with that. So we're doing polling, we're doing focus groups to really get a sense of what people think of the hospitals and health systems. And then we're also looking at, they're asking hospitals to look at their own policies to see where they maybe need to do an internal scrub, sort of a deep dive on themselves. It's probably, I don't know, once a week, you'll see a Wall Street Journal, a New York Times, or a Washington Post story about somebody who they claim is abusing the 340B program or is aggressive in their medical debt. You can sort of go on and on with the list. So we're really going to ask hospitals to take a look, do a critical look at themselves, say, hey, what is our medical debt policy? How do we collect debt? Do we put liens on homes? And it'll be a guidebook, I guess, for lack of a better term. But that's part of it. And then part of it certainly is our communication strategy, where we are now out trying to be out every day with positive stories about what hospitals are doing in their own communities. But it's an issue. It's really something.
All right, we'll go online real quick before Wenji comes with another question. What do you anticipate might be the first areas of action related to healthcare out of the gate after the inauguration? What might take longest, perhaps because they require congressional action?
Yeah, I think that right out of the gate, I know that President Trump has talked about some of his initiatives that he would like to work on. Most of them are not healthcare focused. There are some of the issues that have to do with transgender healthcare, and he talked about on day one trying to cut off Medicare payments to hospitals and health systems that perform some of these transgender services for those under 18. And then with the Supreme Court talking about that decision today, I think that's something that he may bring up and try to engage in a little more. But I do think overall, we're going to be pushed until later in the year if they still do the second budget reconciliation. That's where all of the big policy changes would take place. That's where all of the massive cuts to hospitals would take place. And where anything that we were hoping to get out of the system, stopping the dish cuts, et cetera, will really be focused in that second bill. They indicated it could come as early as August or September, but that's pretty hopeful. But we think we'll be hopefully push off some of the fight till later in the year.
Hey, just a quick follow-up, Lisa, on 340B. So that's a program that costs U.S. taxpayers nothing. There are no savings, right, to U.S. taxpayers or to the federal. This is a program of discounts from pharmaceutical companies to organizations that provide care for the most vulnerable and provide those discounts. How do we get out that message better, right? That there's no savings in this. This is just this, by ending these programs, it's more profit back to pharma and less ability for hospitals then to provide, really needed services for especially the most vulnerable that we serve. How can we help get that message out?
Yeah, I think this goes back to the prior question about the narrative that hospitals are telling. So you have these stories that come out from, mostly 340B, or I'm sorry, pharma-backed groups or pharma-backed research that really goes after the 340B program. And to our point on Capitol Hill, that's what we're trying to explain to them. Say, yes, pharma's like, we want a dollar for dollar, it goes to this and it goes to this, and they don't understand the community benefit that hospitals are providing using these additional resources. But it is a real struggle because for the pharmaceutical company, it's a pretty easy ask to just say, hey, this is not helping, these hospitals are misusing the money, and people sort of look at it more in a fraud issue. So that's also part of our telling the narrative, telling the positive story, and just making certain that hospitals across the country reach out to their local members of Congress or to their local media to explain what they're doing with the program and how it benefits patients.
Thank you.
Let's go online real quick. Some policy folks predict that the new administration will be less concerned about hospital mergers and private equity in healthcare, fewer DOJ investigations and antitrust concerns. Is this your expectation, or what are your thoughts?
I think it's too early to tell. I think that initially people sort of overthought or overview think that Republicans are better on antitrust issues. Certainly under President Biden, the FTC has been very engaged and has made competition in hospitals and health systems a very important issue that they're tracking. We don't have the sense that the Trump administration will be pursuing it that vigorously. But saying that, there are still folks in the administration, and there are certainly folks on Capitol Hill who think that hospital consolidation is increasing the cost. And that's part of the larger problem in some of these minds. So it wouldn't surprise me a lot if consolidation gets brought up in some of these conversations about, okay, well, we won't cut hospitals as much, but you have to agree to start doing some of these different areas around consolidation. So I think it's still open for investigation, I guess I would say. And then on private equity, I mean, I could go either way. I don't know. And I don't feel like the Trump administration is going to be reacting negatively to private equity in healthcare. I think that that's sort of something they're familiar with, and that certainly that President Trump is engaged with and knows those issues. So I do think that private equity as a whole under the administration will be fine.
Wenji, do you have any other questions?
Well, one thing we haven't touched on that we have heard about is tort reform. And so some states, Texas being one of them, does have tort reform, but there's been talk that Trump at a national level in this administration might take on the issue. Thoughts on that? Yay or nay?
Yeah, I do have thoughts on that. You may recall, and again, Texas is sort of different because you guys are in a good spot. But med mal and liability reform were a massive issue probably 10, 15 years ago. They were talked about all the time on the administration, people on Capitol Hill. It really was getting a big push to happen. And then it died down considerably, and folks have certainly talked about it less. There is an attempt and has been an attempt in the past to put medical liability into one of these budget reconciliation bills as sort of an easier way to pass it, which is 51 votes in the Senate and then the majority in the House. This has been tried before. My guess is that they'll talk about doing it again. The issue, again, with this crazy reconciliation and archaic budget process is that you can't put in any provision that doesn't have a substantial economic impact. And so MedMal does save money, but prior to this administration, the parliamentarian who sort of rules what's allowed and what isn't allowed has said that MedMal doesn't have a big enough impact to be included. So that's sort of the one chance we would have to get it in. And it's unclear if the parliamentarian's going to change their views.
All right, Mike, do you have another question?
Well, it's been a terrific dialogue and discussion here. I think you've exhausted all my questions, Lee. I say it's been like we've just been firing them at you here. You've just done a terrific job, and we're just so thankful for the work of the American Hospital Association, really the advocacy for the work that we do, and that's really supporting our communities and taking care of again, the most vulnerable. And I really just can't thank you enough for your partnership and support. I guess I turn it back, Jeffrey, Wenji, if there's any other questions from the chat or anyone else. But again, it's just been a terrific, terrific discussion and dialogue. And I hope those all on the line today have enjoyed the discussion as much as I have.
Jeffrey, I do have one question, final
Sure.
question for Lisa,
Sure.
and then I think we just got one online, so I'll let you preview that one. You know, you and your staff we work with on a regular basis, and you tirelessly advocate for us on the Hill and amongst many other places. What's the one thing a hospital member could do to best support AHA?
Oh my gosh, thank you for asking that question. It really is, they need to engage their members of Congress. They need to tell their own story. They need to make certain that both their local officials, their congressional officials or senators are all aware of what they're doing, the care they're providing, and the benefits to their patients and community. Luckily, AHA has a good voice on Capitol Hill, and it's a very well-respected organization. But every time we go into an office, they say, well, I haven't heard from my local hospitals, or how is this impacting my local hospitals? So really the most important thing that hospitals can do on this advocacy front is just to have a relationship with their members of Congress, invite them to tour the hospital, ask them to do town hall meetings. It really moves the ball forward, I think, on educating lawmakers on what's happening day to day in the hospital. So thank you for asking that question, and please reach out to your members of Congress, all of you.
Thanks for asking that question, Wenji. I think that was spot on, and I think it also allows us to really kind of encourage our alumni who are in hospitals to really kind of do exactly what Lisa is saying. And I know here in North Carolina, we work very closely with the North Carolina Healthcare Association as well to make sure that that happens. The question that came in, what are you looking forward to in the healthcare sector in the next 4 years?
Oh gosh. I feel like I don't have an answer for this because I've been so mentally prepared that we're expecting this really tough year next year. Oh my gosh, there has to be something I'm looking forward to. Am I a horrible person if I can't find anything?
No, it's totally fine. I mean, again, you have been taking these questions for the last 30, 45 minutes, and I have been blown away that there has not been a subject that you haven't had some sort of knowledge on. And so that is pretty impressive. I mean, I've been blown away with how you have responded to all of these topics. And it speaks to, how effective you are in your role. And so we are appreciative of you taking time to join us today. And I think that I don't have any more questions from the webinar. Wengie and Mike, I don't think you have any additional questions, but this has been such an informative opportunity to be in this dialogue with you. We appreciate you just taking time out of your schedule. I can only imagine how busy your schedule is now with the transition that is happening. So thank you for taking the time to meet with us, and also thanks to our HPM Alumni Council, again, that's chaired by Wengie. Mike is a member of that Alumni Council. Ann Jacobs and Anna Alvarez are all also online, and they're members of that Alumni Council for making this happen. This is a part of a Lunch and Learn series that we try to offer each semester. And so who knows, we may be back again in the spring, Lisa, asking what does this look like now that we a few months into it. But that would, I think we had great response for this webinar. And so we're really excited and appreciate you. And also I cannot end this webinar without thanking Stephanie Bazakas and John Wise, who made this happen. They're the folks working behind the scenes to make sure the webinar stuff, because if I had to do it, I don't know what we would be doing. But they did it. And so thanks so much for that. And Lisa, we are here if there's ever anything that the UNC Gilling School of Global Public Health, specifically the Department of Health Policy and Management, can ever do to support you or help you out, please feel free to reach out. We've got folks who are doing research in a lot of the topics and areas that that you mentioned, and specifically the rural hospital side of it. Our Cecil Shep Center does a lot of the research in rural hospitals, and you're probably familiar with some of those reports, and some of our faculty have testified. And so we are here to support you in whatever way that we can.
Great, thank you. Well, thank you all for inviting me and allowing me to talk a little bit about what's happening here in town. And everybody reach out to your member of Congress.
That's it. That's the marching order from there. All right. Thank you so much. We're going to now close the webinar. Have a good day, everyone.
Thank you.
Bye-bye.
Thank you.